Hi, this is Brian Kim. I'm going to share with you case number 27 in the Best Way to Do Cataract Surgery series. I'm presenting this case because I want to discuss the RK incisions. So there's two basic RK incisions, the ones that are wide enough where you can actually place your own keratome incisions. And you want to make sure you place your incisions in between the RK incisions. But then there are others where the RK incisions are too close together and you actually have to do a scleral tunnel. But in this case, the incisions are far enough apart, and you'll see that I'm able to strategically place my own incisions between the RK incisions to do the surgery. So I use a corneal marker to help me center and size my rhexis. I use a cotton tip to help me do this. And then I'm going to use a cotton tip to help me make my presentesis incisions, first on the right and then the left. I'm using the cotton tip to turn the eye so I can make a flat approach, so I can make my incision parallel to the iris plane for a self-sealing incision. I'm injecting some intracameral epinephrine and lidocaine, and then dispersive viscoelastic. I'm using the cannula to hold the eye, and then I'm going to make my triplanar corneal incision. I'm going to make a vertical groove, and you can see here this is very important. I'm going to make sure I get in between the two RK incisions. I'm going to do a tunnel through the cornea, but make sure I don't go too far. You can see I'm going very slowly, making sure I don't infringe into the RK incisions, and then I go in. And I'm able to make a nice incision, triplanar incision between the RK incisions. I start my capsule rhexis, do a puncture style technique, and I pull downward. You can see I'm getting a little bit of a flap there. I'm just teasing it very gently, and then I'm able to grab it there on the left side. Start to create that flap, grabbing intermittently, making sure I get it right where I want to as far as the diameter of the rhexis, and then I start going around circumferentially. I'm grabbing and re-grabbing as I go, and I want to grab intermittently every 1 to 2 clock hours. This helps reduce the risk that I'm going to have a run out. I try to follow the marks of my corneal mark, which will help me center and size my rhexis. Again, I'm just going very slowly and methodically, making sure that the mark is followed all the way around. I complete the rhexis now, and then I burp some viscoelastic out of the eye. I start my capsular fornix hydrodissection technique, place the cannula out to the contralateral equator, underneath the rhexis, pointing down, get a nice fluid wave, decompress to the right side, and then I'm going to start to spin on the left side. You can see I'm turning the tip downward to help leverage my ability to spin the lens. I irrigate the surface and then lift the eye with irrigation off, enter with the phaco tip. This is to help minimize Descemet's trauma. I'm removing the surface epinuclear material, go underneath the epinuclear ridge, which ensures I'm definitely within the bag. I place the phaco tip vertically, subincisionally. I push both instruments together, which crushes the lens in half. I place the chopper out to the contralateral equator. You pull the chopper centrally toward the phaco tip, and this crushes the right heminucleus in half. I go ahead and start to emulsify the first quadrant, which comes out quite easily, and then I'm going to prolapse the second quadrant up with the chopper, and this also is emulsified quite easily. I turn the second heminucleus in front of me, place the chopper out to the equator, and then I crush the lens between the chopper and the phaco tip. You can see that this is a softish lens. I'm able to very gently and easily emulsify and remove the endonucleus. You can see the CDE is 0. So now I'm going to remove the epinuclear material. Again, I grab the anterior portion of the epinucleus and it just tumbles out quite nicely. Whenever you're removing the last remnants of the epinucleus or the endonucleus, you always want to place the chopper out deep into the bag to protect the posterior capsule from the phaco tip. I take the chopper out, push BSS, take the phaco tip out, replace it with the INA handpiece, and then I begin my cortical cleanup. I'm starting subincisionally, removing the cortex, and this I do because the cortex is in its most intact form and it's the most stable form, and the cortex does protect the posterior capsule. I like to attack that subincisional cortex first. As I go around circumferentially, and with the help of this polymer tip and the high vacuum, I'm able to very easily and controllably remove the cortical material. I then switch to the polish mode and I polish underneath the anterior capsule edge to remove the lens epithelial cells. You can see I'm going around and polishing underneath the anterior capsule. Once I finish polishing underneath the anterior capsule, I'll begin to polish the posterior capsule as well. So now you can see the underside of the anterior capsule as well as the posterior capsule are now nice and clean thanks to this polymer tip. So I'm going to go ahead and push BSS through a paracentesis incision into the subincisional capsular fornix to make sure there's no cortical material. This was clean. I'm going to switch it with a cohesive viscoelastic cannula. So now I'm going to use a capsule sweep. I'm going to sweep underneath the anterior capsule first on the left side, making sure I'm getting rid of any cortical material or lens epithelial cells. And then I'm going to switch and polish to the right side as well. And you can see that this bag is fairly clean after all of the work that we did with the INA polish mode. I'm going to inject my single piece acrylic intraocular lens into the capsular bag, making sure the leading haptic and the optic are in the bag. And then I'm going to switch to the INA. I use the INA handpiece to tease the haptics off the optic. I go underneath the optic and turn the lens 90 degrees clockwise, and I tilt it to make sure that both haptics are within the bag. I'm starting to polish underneath the anterior capsular rhexis edge, but I also see some cortical material between the lens and the posterior capsule. So I go back underneath the lens and remove a little bit of that fine cortical material. Once the bag is completely free of the cortical material and viscoelastic, I remove the viscoelastic from the anterior chamber and the angle. I push BSS through my paracentesis, and I'm flushing the angle to make sure there's no viscoelastic, making sure that the anterior chamber is completely free of that dispersive viscoelastic material. I then take the INA handpiece out and I hydrate my incisions. So again, this is an RKI. The main thing is, are the RK incisions far apart enough to place your own incisions for cataract surgery? If the answer is yes, you have to strategically place your incisions in between the RK incisions. If you're not confident that you can do that, then it makes more sense to do a scleral tunnel to make sure that you don't cut into the RK incisions and have trouble with fluid egress during cataract surgery. I also perform double chop and cross chop and utilize mechanical fracturing forces to crush the lens material into smaller pieces. I utilize no ultrasonic energy with this case. I was able to remove the lens pieces atraumatically from the capsular bag. I did a gentle and very controlled technique of disassembling the lens. You saw using the corneal marker to help me center and size the rhexis. You can see I have 360 degrees overlap with my rhexis on this lens implant. I made flat corneal incisions to give me a watertight corneal incision. So by following these simple principles, I'm able to perform a very gentle and well-controlled cataract surgery with an excellent placed lens implant, avoiding the RK incisions, and the patient did well. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.